Good evening, good afternoon, and good morning, everybody. I am Dr. Mohit Bhandari, Bariatric Metabolic and Robotic Surgeon from Indore in India. I welcome all of you for the 24th episode of Virtual Bariatric University. This is tough times here in India, and we are having our second wave of COVID-19 pandemic, so much so that our city is in a state of complete lockdown. And to do this webinar live, we all are so grateful to you that you have all gathered here to make this event successful today. And I hope that the news I received is that the situation across the world is again getting towards the worst side like last year. But I'm so thankful to God that all of us are keeping fit and healthy, and we are still able to meet each other, although virtually, but through this platform. Today, we have a very interesting topic, laparoscopic banded sleeve gastrectomy. And all of us know that sleeve gastrectomy, being one of the most commonly performed procedure, is hugely exposed to the problem of weight regain and recidivism. And therefore, if we preemptively band our sleeves, are we saving those many number of weight regains and those many number of revision, because the patients will maintain their weight for a long period of time? That is what we are going to learn from this episode. I take this honor to welcome our first faculty, Dr. Paolo Gentileschi from Italy. Paolo is a Director and Chief of Bariatric Metabolic Surgery Unit at San Carlo di Nancy Hospital in Rome. Since 2012, Paolo was the Director of the Bariatric Surgery at Rome Tor Vergata. He was appointed as the Chief of Bariatric Metabolic Surgery Unit, and since then he performed more than 5,000 laparoscopic bariatric procedures. He has been elected to the Scientific Board of Italian Society of Obesity Surgery, the Italian Society for Day Surgery, Endocrine Surgery, and also the Italian Society for University of Surgeons. One of the most recognized and one of the most accomplished surgeons, he was the president of 2 international congresses of these societies. Welcome, Professor Paolo, to the Virtual Bariatric University. Next, we have Professor Luc Lemens from Belgium. Luc is the head of surgery at AZ Nicolas Hospital in Belgium. He is one of the pioneers of obesity surgery in Belgium and is performing bariatric surgery since 1982. He was the president of the first IFSO European Chapter Congress in 2014. He's a founding member of the Belgium Associations of Bariatric Surgeon, of the Belgian Obesity Surgery Society, and is a treasurer of BESOMS. Nowadays, the most frequent operation he performed is a banded gastric bypass and sleeves. And I think across the world, he has the largest amount of experience with that volume, right person to comment on these kind of procedures. Welcome, Professor Luc Lemens. Another friend from US, Professor Andre Teixeira. Andre is a bariatric and foregut surgeon at Orlando. He's a vice chair of general surgery since 2017, and now the coordinator, co-director for the bariatric surgery fellowship since 2014. He's the vice chair for ASMBS, on the video committee and quality and outcome committee and equality committee for ASMBS. Several papers have been published, video presentations and publications for Andre. Andre is also one of my closest friends I have in US. Andre, welcome to this show, the Virtual Bariatric University. You are coming here for the first time, and myself and Professor Fobi, we are so honored to invite you. I have with me Dr. Jodok Fink from Germany. Jodok is a consultant surgeon for visceral surgery, for bariatric and metabolic surgery at the Department of Surgery, Medical Center, University of Freiburg. Jodok has extensively published on banded procedures, and that's why me and Professor Fobi, we thought that when we are talking about banded sleeves, we should have him on the show so that he can share his experience. Welcome, Jodok, to this show. We have another friend from United Arab Emirates, Professor Patrick Noel. Patrick is a great researcher and one of the most prominent publishers in the field of bariatric surgery. He is now a consultant bariatric surgeon with the Emirates, surgical advisor to the Endeavor. He's a founder and CEO of Less French Surgeons de Dubai. In the wake of COVID-19 pandemic and increased difficulty to access hospitals, he created a digital platform gathering most of the French-speaking experts in multiple surgical and medical specialties to interact, help patients during the COVID-19 pandemic. In the past, he was the head of bariatric metabolic surgery at the American Surgery Center in Abu Dhabi. He is one of the active members at ASMBS, IFSO, American College of Surgeons, and several others. So welcome, Patrick. And you've been to our show before also, and we were so honored and so grateful for you to accept this invite for the second time and come to us at the virtual Bariatric University. Professor J.S. Rajkumar from India. He's currently the chairman and chief laparoscopic surgeon at Lifeline Hospitals. He set up a first stem cell unit in Chennai and successfully carried out stem cell therapy for paraplegic patients and has, to his credit, 30,000 happy patients till date. J.S. Rajkumar is the first Indian surgeon to have performed air surgery live with use of Google Glass. This process was frequently used abroad, but not in India. He has been the chairman of the Associations of Surgeons of India of the Tamil Nadu chapter, has been conferred with Vidya Ratan Award from the President of India, awarded Best Doctor Award from the IMA in Madurai branch, and awarded Surgical Par Excellence Award from the Associations of Surgeons of India, Tamil Nadu chapter branch. Welcome, Professor J.S. Rajkumar. We have Dr. Ramesh Makam from India. Ramesh is from Bangalore. He has 30 years of experience in minimal access surgery, a great teacher, a researcher, performed more than thousands of procedures in 15 years. He established the Bangalore Endoscopy Surgical Training Institute, and he trained more than 1,600 surgeons from across the globe by his novel teaching methodologies, and has established one of the most prominent training centers. He's also the founder member of the Hernia Society of India. Welcome, Professor Ramesh. He's been a great friend and one of the Indians we are proud to have in the community of laparoscopic surgery. I'm pleased to introduce Professor Dr. Mahak Bhandari from India. He's a consultant surgeon at SIEMS Medical School and also a consultant with me at Mohak Bariatric and Robotic. He's a director at Bhandari Hospital and Research Center, works as associate professor at Sri Aurobindo Medical College, Indore. He's a laparoscopic bariatric surgeon at Mohak Bariatric Center, trained under Dr. Fobi and myself, and also now the managing trustee of the Sri Aurobindo Institute of Medical Sciences, University, Indore. Welcome, Mahak, to the virtual Bariatric University. It's an honor to introduce you. Last but not the least, with my mentor, my teacher, and the clinical director of this center, Professor Fobi, and myself, Dr. Mohit Bhandari, we have this honor to invite all of you here on this show. And I hope all of you are keeping safe. May God bless all of you. It's a very tough time here in India and across the world, but I think all of us are going to fight this and come up with flying colors. At this time, I would like to invite Professor J.S. Rajkumar, Patrick, Noel, Andre, and Ramesh to moderate the first lecture session. Thank you.
Yes, I'm Dr. Ramesh here. I would like to invite Dr. Fobi to start. Can I
go ahead?
Use Dr. Fobi, please? Yeah, this who doesn't know Fobi? I don't think bariatric surgeons need his introduction, but anybody getting into bariatric
University
definitely would like to know about him. Dr. Fobi is an internationally acclaimed bariatric surgeon and is known as Hollywood's weight loss surgeon and has made thousands in US, including many Hollywood heavyweights leaner and fitter. His patented inventions and procedures are helping surgeons across the globe, and his surgeries brought smiles on thousands of faces. Dr. Fobi is credited with 20 research projects on surgical treatment of obesity and outcomes, has made more than 450 presentations, local, national, international, and he has contributed over 40 publications in obesity and bariatric surgery. He has been a leader in this field, being the president of the International Federation of Surgery of Obesity between 2008 and 2009, the past president of the California chapter of American Society of Bariatric Society, and the president of the ASMBS in 2006 to 2008. The Fobi pouch is a version of stomach shrinking bypass and is now used around the world for the treatment of obesity and is one of the most effective surgeries. His experiences over the last 4 decades in bariatric surgery is fantastic. One of the few people today you see who started with open bariatric surgery and then went on to get into laparoscopic bariatric surgeries at a very senior level. He was already a professor, and at that time to adapt to laparoscopic surgery, and that too to one of the toughest laparoscopic surgeries, was phenomenal. I was mentored by him. I was already doing everything in laparoscopic surgery, including Whipple's procedure, but I was scared to do bariatric surgery because nobody in our country were doing that. And in 2003, I went to his center in Los Angeles and did my fellowship under him. What I saw was a scientist, not just a surgeon, who had a very meticulous way of maintaining data, analyzing data. He had 55 people in his staff in his office. He was full of energy for 18 to 20 hours a day. And more than anything else, I'm not saying just as a surgeon, but he was a great human being. So I've known him for 18 years and I cherish my relationship with him. And today I would like to invite him to give deliver his talk, which we are all looking forward to.
Thank you. Himanshu? Mohit Bhandari. My disclosure is I'm the founding president of Bariatric Corporation, a corporation that makes rings for bariatric procedures. I also had a gastric bypass for type 2 diabetes 10 years ago. My diabetes is in remission. I've lost about 58 pounds, which I maintained for the last 10 years. The case mix here is that of Mahak Bariatric Robotic Surgery Center, where about 15,000 cases have been performed over the last 10 years. There have been a variety of procedures from endoscopic to laparoscopic to robotic procedures. A name makes a lot of difference. In 1981, when it was difficult to get acceptance of the gastric bypass because of the word bypass in the phrase gastric bypass, because bypass conjured memories of intestinal bypass, an operation that had a moratorium imposed on its use because of complications, I used the name a limiting proximal gastric pouch with a row-wide gastroenterostomy to treat obesity to call the gastric bypass. This was accepted readily. The long name was shortened by the lay public to the pouch. And ultimately, the gastric bypass name was accepted. Bariatric metabolic surgery is replete with names evolving. Vertical banded gastroplasty evolved to stomach stapling. Biliopancreatic bypass evolved to BPD. Gastric banding evolved to the lap band. The mini gastric bypass evolved to OAGB. Operations with a prosthesis placed loosely around the proximal pouch to form a pseudopylorus have been called banded operations. Banded gastric bypass, banded sleeves. Unfortunately, there has been reluctance in accepting these operations in the bariatric community, in spite of publications that demonstrate that they are superior to their counterparts. The word band conjures the memories of the laparoscopic adjustable band that was highly popularized only to be abandoned. Operations with a prosthesis placed loosely around the proximal pouch to form a pseudopylorus have different mechanisms of affecting weight loss and maintenance. These mechanisms are different from that of the laparoscopic adjustable band or the previously popular vertical banded gastroplasty. These operations should not be called banded operations. That is, they should not be called banded gastric bypass or banded sleeve, because I've come to realize that band or banded is a 4-letter word in bariatric metabolic surgery. A gastric bypass or sleeve gastrectomy with a prosthesis placed loosely around the proximal pouch to form a pseudopylorus should be called gastric bypass with a pseudopylorus or sleeve gastrectomy with a pseudopylorus. We know that the pouch, stoma, or proximal jejunum dilates, and dilation is part of the natural history of bariatric metabolic procedures which have a pouch. In a significant number of patients, this dilation results in either inadequate weight loss or weight regain. We have shown that patients who have a prosthetic pseudopylorus, this dilation is controlled and therefore provides for weight loss and weight loss maintenance. This pseudopylorus provides for early sense of satiation, the full sense effect. The pseudopylorus provides for control of the appetite and reduces eating. This is based on the fact that there's vagus stimulation of the afferent nerves to the hypothalamus. The prosthesis around the pouch generates a 24-hour per day background of signaling that induces a sense of satiety. Gastric bypass sleeve or one anastomosis gastric bypass with a prosthetic pseudopylorus have been documented to have better weight loss and better weight loss maintenance. Complications of bariatric metabolic surgery with pseudopylorus include migration, slippage, and hypertrophic reaction around the prosthesis. These patients normally present with dysphagia, regurgitation, vomiting, complete obstruction with nutritional and electrolyte balance, particularly thiamine deficiency. Occasionally they present with bleeding. But in all and overall, there have not been any deaths reported from complications of patients with the prosthetic pseudopylorus. Management of complications due to prosthetic pseudopylorus include expectant observation, spontaneous prosthetic extrusion, endoscopic prosthesis extraction, induced prosthesis migration with a stent or repeated balloon dilation and prosthesis extraction, laparoscopic prosthetic extraction with or without dilation, and laparoscopic reintervention with prosthesis removal and conversion. We have observed that prosthesis removal is usually followed by weight regain. However, patients rarely request the removal of prosthesis. On the other hand, patients normally demand that the prosthesis be replaced in cases where there was erosion and removal. Unfortunately, many physicians who see these patients recommend prosthesis removal when a patient has any problems with intolerance, whereas the most the patient needs is nutritional counseling. Nutritional counseling is the best management for food intolerance. The patients will show the normal findings of the endoscopy and the contrast follow. A popcorn test is a good test for patients who have food intolerance. Patients should be given popcorn to ingest, and they will find out they can tolerate it. Who should have a metabolic operation with a pseudopylorus? Definitely super obese patients and other patients who want it after weighing the benefits of the cost. Operations with the pseudopylorus belong to an armamentarium of bariatric procedures. Bariatric procedures are tools that surgeons provide to the patients to effect weight loss. No one operation fits the needs of all patients. Choice of the operation should be tailored to the patient's needs. I conclude by saying that a gastric bypass or sleeve with a prosthesis placed loosely around the proximal pouch to form a pseudopylorus should be called a gastric bypass with a pseudopylorus or a sleeve gastrectomy with a pseudopylorus, and not use the word banded procedure. Thank you. We at Mohak offer various treatment modalities for obesity. The operation is determined by the profile of the patient and guided by findings from analysis of data from our prospective maintained database and other scientific publications. I'll entertain any questions based on this presentation. Thank you very much.
This is a very illuminating, intelligent lecture, and I think we need something dramatic like this to happen. We always have been looking at gastric band in India as a failure. There has been no surgeon who had good experience with gastric band, adjustable gastric band in India. And we would always say band is banned, B-A-N-N-E-D. So you have to ban a band. But then we have a totally different band here. The physics is totally different. We have one band, the adjustable gastric band, which squeezes the pouch, and we have another loosely lying around it. And as the stomach dilates, it's going to touch it, and then it is restricted by this Fobi band. So I think both are totally different, but then when we call both with the same name, we've always had a problem. Patients never understand, even surgeons don't understand it correctly, and we've always had a confusion. Because the minute you say a band, everybody feels all bands work the same way. And we had a band that was being used for 15 to 20 years, having complications. And we don't want this to be similarly understood. These are my comments. 10 years ago, when I started using a band for a sleeve, of course, we were using for the bypass, which was fully proved by Dr. Fobi to be great. I had gone through multiple publications and we were doing that. But when I started using it on a sleeve in 2011, even Dr. Fobi, who's, as I said, a scientist, was not very sure whether we should be using it. We were looking at it as a research protocol, and then we had excellent results over 10 years. And today, I think Dr. Fobi is quite convinced that we have a fantastic procedure which is effective and safe. These are my comments. Any other questions would be welcome.
I have a question. Dr. Fobi, great lecture. But as you know, I'm from the USA, just like you. So, you know, I've been watching you guys' data for a long time, and phenomenal data. What you group, you and Mohit are doing in terms of banded and unbanded comparisons. Well, as you know, the experience that we had here in the USA was not very good with banded bypasses. Granted, the band that was done back in the days were a little bit different, with a celestic ring or some people putting mesh. What is different about the band that you guys are putting now versus the band that was done many years ago? I'm just trying to, the physics behind it. Because it seems to me sometimes we can put it very loosely, and sometimes we still having issues with dysphagia, reflux disease, and so forth. I'm just trying to understand a little bit more the dynamics of the bands that you guys are using now.
I hope you can hear me. The main difference is in what we're trying to accomplish. The mesh prosthesis, this ring prosthesis used in vertical banded gastroplasty, and the adjustable band used in the lap band procedure, they were restrictive. You could feel the band was placed tightly around the pouch, and that was the mechanism of the function. We had that same impression when we started using the devices around the pouches in the gastric bypass. As a matter of fact, that is how we learned about using a ring, because patients whom we revised from a VBG to a gastric bypass did well and better than those without a ring. And we introduced this. But with time, there's been a lot of research. Doctors from all over the world. Luke Lemons is here. Dr. Conrad in Germany. My friend Richard Stops in Australia. Salinas in Venezuela. Dr. Awad in Chile. Rafael Capella in New York. Over the time, we realized that we did not have to place the prosthesis around the pouch so fixed. The principle was to prevent dilation of the pouch. And so you were creating a pseudopolaris, which is not that restrictive. So basically the difference between this and what we did before is that the ring or prosthesis that is placed around the pouch is placed loosely, and the patient during the first couple of months cannot tell the difference between the patient that has a ring and the patient that does not. But as that pouch stretches, the patient finds there's a limitation. So the patient is forced, when they progress from a liquid diet to a full diet, to realize that they have to chew their food thoroughly, take small bites, eat slowly, and choose small portions. And these patients adjust to it and accept it. And that is the mechanism that is different. Whereas with the VBG and the lab band, originally the patient has to do that, and they don't understand and they don't take a time to learn. I hope that explains.
Thank you. Explained it very well. Thank you very much.
I have a question.
Yeah.
How can you explain the low rate of acceptance with the surgeon for the band gastric banded bypass or banded sleeve or prosthetic pseudopylorus sleeve and bypass? Surgeons, they know that it's very efficient regarding the weight loss, and especially with bypass. Why is so difficult to do that? There is a low rate of acceptance everywhere.
That is a very good question, and that is why I gave the lecture today. It wasn't too scientific. I was being more, giving it from the point of an inventor. The reason it's not accepted is simple. Fortunately or unfortunately, what is accepted in America is accepted around the world.
Yeah.
Number two, to accept a prosthesis in America, you have to go through what is called an FDA approval. And we tried to do that. Unfortunately, I had poor investors, and I used most of my own money. And at the 5 million mark, I ran out of money. And the FDA we had planned the study for a 1-year outcome to show that the prosthesis was in place. The FDA accepted that protocol, but at 1 year they said, well, your claim is that the prosthesis provides for weight loss maintenance. So you have to give us 5 years data. Well, anybody who has been involved in clinical trials knows what it cost. After spending the first $5 million, we raised some more money to carry the trial further, but the study had been planned for a 1-year follow-up. And by the second year, the follow-up had gotten down to 70%, by the third year to 17%. We couldn't find the patients, and so the surgery died a natural death. And so the only people that were able to use the ring, and we did a study with the doctors, which Dr. Paolo is going to talk about, in Italy, and some of the study was done in Germany by Dr. Fink and his group, Dr. Conrad, were the other ones that could continue using the ring in Europe where a CE mark was available. So that is the reason. And then, but the primary reason is, if you look back in 1996 through 2004, the Fobi pouch was very popular in the United States. Every doctor was making a prosthesis with Prolene, with mesh, with whatever they could. Then laparoscopic surgery came in. And all those old surgeons who knew the benefit of the banded procedure stopped doing surgery. And we had young, good surgeons like Shower, McDonald, and a few that did laparoscopic surgery who did not know anything about the bandage. And when you do this operation, and so they did not see the need for the ring. Later on, they did, but by that time, there was no ring available for them to use. And so the ring kind of faded away naturally in the United States. Now in Europe, I think we have 2 or 3 devices that are certified by the CME MAC, and that's why you have this device being used in Europe, the Middle East, Asia, and other parts of the world. We're trying to rekindle FDA studies to do that in America, but raising the funds at this time is the main problem. I hope I answered your question, even though it was lengthy.
Yeah, definitely, Mal. Thank you.
Thank you. All right, I'll say we'll go on to our next speaker. I think, all right, I'm going to introduce my colleague. Dr. Rajkumar could not make it. I think he's tied up in the OR running late. Raj, did you join us? Okay, he's not here, so I'll introduce Dr. Gentileschi, Chief Bariatric and Metabolic Surgeon in Rome. He had been introduced by Dr. Bhandari. Paolo, we're glad to have you here, so we'll go ahead with your lecture. Thank you.
Good morning, everybody. First of all, I would like to thank the people of the Virtual Bariatric University and mostly the course directors, Dr. Mohit Bhandari and Dr. Fobi, for inviting me to speak about a procedure that I certainly know very well. I think that banded sleeve gastrectomy is a new procedure, but has many advantages over the sleeve, the traditional sleeve. This is my new location. I'm the director of the Bariatric and Metabolic Surgery Unit in San Carlo, which is a huge hospital in Rome. And we are a high volume center, and we do more than 1,000 bariatric procedures per year. The surgical technique of the banded sleeve gastrectomy is certainly important and has many implications in the results of the procedure in morbidly obese patients. This is my opinion, and is reinforced by what is going on in literature. This is the typical picture of a banded sleeve. The ring we are using since many years is the minimizer ring, and I think it's the best tool. It's the best tool for this procedure because it has many advantages, as we will see later. We did many procedures of banded sleeve gastrectomy, but mostly we focused on randomizing vertical banded sleeve versus versus randomizing banded sleeve gastrectomy versus traditional sleeve gastrectomy. So this is the first study we did in 2014, and the results were quite clear, meaning that most of the outpoints that we looked for were similar between the two procedures at 1 year. But what was more important for me is that the complication rate was similar and the operative time was similar. So the fact that we banded the sleeve did not add any further complication in the postoperative period and in the short follow-up of 1 year. We continued in this trial and we published the second results in 2020. And these are midterm results. And what we saw is that the weight loss after banded sleeve gastrectomy was superior to the traditional sleeve, especially in the long term, in the midterm at 48 months after the procedure. And this was quite clear. And so we stated that the banded sleeve is a safe, feasible procedure, and the time required for the device positioning did not influence significantly the surgical time, and the results of body weight loss were different, being the banded sleeve associated with a greater weight loss compared to sleeve. And this is the demonstration of it. So bending the sleeve seems a good choice in patients with sleeve gastrectomy. Of course, the rationale for bending the sleeve is not creating a stenosis in the gastric stump, but is creating a situation that prevents dilation in the long term. This is the rationale for the procedure. We don't want to create a narrow sleeve. We don't want the patient vomit more times than the traditional sleeve. We just want to put a tool that prevents the gastric stump from dilation over time. And that's the reason why we put the ring very loose in the gastric stump, as I'll show you in a nice video. We have two traditional techniques of bending the sleeve. This is a perigastric technique. We open the pars flaccida technique, and this is not a perigastric, sorry, this is a pars flaccida technique. So it's easy, very easy at the end of the procedure to create a retrogastric tunnel. We are used to put the ring roughly 4 or 5 centimeters below the gastroesophageal junction. As you can see in the video, the ring is quite loose. We don't want to create a narrow sleeve. We fix the ring over the sleeve in order to avoid postoperative gastric stump dilation over the ring or ring slippage. And this is so you can see that the Joanne, the grasper, can go easily through the ring at the end of the procedure. So this is a high resolution image 3D of banded sleeve gastrectomy. As you see, the ring is quite in place. There is no creation of a dilation of the stump over the ring, but and this is fundamental for a good surgical technique. I believe that a good surgical technique prevents complication even postoperatively, and also either postoperatively or in the long term. You see an X-ray of a patient with a ring. The ring is placed 4 or 5 centimeters from the gastroesophageal junction. The contrast media pass easily, very easily through the ring, so there is no stenosis. Otherwise, we will have a higher risk of a leak over the ring in a gastric stump. And the fixation of the ring is fundamental to avoid long-term complications. So we have the creation of a retrogastric tunnel, and we have two techniques, the pars flaccida technique and the perigastric technique. Both techniques are good. We always start medially to lateral, starting 4 or 5 centimeters from the gastric esophageal junction. The pars flaccida technique is easier, of course, because you don't have to go close to the gastric wall, but you need probably a larger ring, or if you use a minimizer, which one size fits all, you have to close the ring at the first step, because of course you will have some fat between the ring and the gastric wall, and for someone this prevents the ring from eroding the gastric wall. The perigastric technique is a little bit more difficult because you have to go close to the gastric wall and you have to avoid some bleeding, which can occur. But the pros of the perigastric technique is that you can either tight the ring more efficiently, or you can close the ring at the second step. And this, according to some authors, is a technique because it is more restrictive compared to the pars flaccida technique. I think that both techniques are good. The ideal technique is that one that the surgeon prefers. The importance is to not close tight the ring over the gastric stump and to fix the ring in order to avoid slippage. I had in roughly 400 banded sleeve, I had just one ring erosion and one ring slippage. So I think that the rate of complication is quite low, and the incidence of leak is quite similar to the one of the traditional sleeve, which is around between 1 and 2%. So grab the ring from the R blue side and pull it over the sleeve. I always, you have to be careful of putting the ring in the proper position. And when you close the ring, you have to be careful to have the bougie inside in order not to tie, in order not to narrow the gastric lumen. Once you have closed the ring, I do the bougie removal, and once the bougie is in the esophageal, gastroesophageal junction, I do the metal and blue test for checking eventual leaks. So the ring has to be left in place in a loose fashion. We don't want to create a stricture which would increase the pressure and the gastric leak incidence. And we, as I told you before, remove the bougie and fix the ring over the gastric tube. This is our most recent paper. It's about 210 banded sleeve gastrectomies. And now we are up to 400 roughly. And as I told you before, the complication rate is quite similar to the traditional procedure, and the weight loss is definitely superior in the long term, and we demonstrated it in a randomized trial. This is another video showing the perigastric technique. We go a little bit closer to the gastric wall. The retrogastric tunnel is already being prepared, and we put the ring in the usual fashion. This can afford you to close the ring a little bit more tight over the stomach. And I think that the technical steps are: do a traditional sleeve. It has not to be different from a traditional sleeve. So we use the same bougie. We are used to use the 36 bougie. Put the ring roughly in the position I told you before. Cut the blue arm that is useful to put the ring, and then put stay sutures. So the surgical technique of the sleeve has to be the same of the traditional one, and the time to add the ring to the procedure is really a couple of minutes. And in our experience, this procedure is quite safe, and the weight loss in the long term seems superior. Of course, other works are coming and other randomized studies are needed, but I can tell you right now that the complication rate is good and the procedure seems safe. Of course, I'm waiting for some more randomized trials in the future, and I hope that they will demonstrate that this is a better procedure compared to the traditional sleeve. Thank you.
Okay. Thank you very much, Paolo. That's a very nice explanation of the technique. You stressed the two important points: placing the device not further than 5 centimeters from the gastroesophageal junction, and placing the device loosely around the pouch so it is not constricting. At Mohak, we did both perigastric and pars flaccida, and we have noticed that there's slightly increase in the slippage rate with the pars flaccida technique. We think that if you do that, you would have to anchor the device at 2 locations: at the pars flaccida and on the greater curvature of the stomach on the staple line. I wonder whether you do anchor it in 2 places, and have you seen a difference? Paolo?
Yeah, no, I can comment that I've not seen this difference, but of course, it doesn't say anything. I mean, you may be right, but in my experience, I've not seen this difference between the two techniques, because we had only one slippage in 400 cases, and I don't think it was a pars flaccida technique, the patient had a slippage actually, but the numbers are too small. So I cannot comment on this. I think that we need a lot more cases to say this.
Okay, the other comment I make is to stress on what you've said. One of the advantages of using a prosthesis is that you do not end up trying to make a sleeve too narrow, because the ring enhances the restrictive mechanism. And when you make a sleeve not too narrow, then you limit the probability of having a leak at the gastroesophageal junction. And we have noticed that we have very few leaks in the banded procedure compared. As a matter of fact, in our series, it was 50% less in the banded procedure than in the primary procedure, because in the standard sleeve procedure without a ring, in order to make it more effective, we make the tube a little bit narrower. But when you place a ring, you can make a pouch which is slightly more generous. Okay, I'll turn this over to the next moderator who will introduce our next speaker. Go ahead. Vishal?
My side. My name is Jodok Fink, and I'm professor for surgery at this university here in Freiburg, Germany. I want to thank the organizers, Mal and Mohit, for inviting me to again present data on banded sleeve gastrectomy. And the task given to me this time was weight loss, complication, and resolution of metabolic comorbidities after banded sleeve gastrectomy. And I hope I can show you some nice data. These are my conflicts of interest. So Paolo has shown you a lot about technical aspects of banding a sleeve, so we can just jump right into the data. So first task was weight loss. If you look at early weight loss after banded sleeve gastrectomy compared to a non-banded sleeve, you see, and this is data from our group in 50 patients, and you see that there is not a whole lot of difference. But this is something we would have expected, because first of all, we see the same thing after banded gastric bypass compared to regular bypass. And second, the ring is placed loosely around the sleeve or the bypass. And then, it needs some time to actually work, because it will work when the underlying procedure pouch will dilate. And this happens after 3 to 5 years. And that's where you see a gap opening in weight loss. And this is retrospective data from our group in around 100 patients. And you see the delta and axis weight loss was 14%. If we look at the Indian data from Mohit doing more or less the same thing in a quite similar setup, you see that the delta and axis weight loss was even 30% after 5 years. And this is definitely something that's highly clinically relevant. Now, if you look at all these graphs, you can see that the main gap comes to existence because of the lesser amount of weight regain in the banded sleeve gastrectomy group. And this is something that Luc Lemmers from Belgium nicely worked out in his group. And look at the percentage of patients that regain weight. This is 20 versus 2% of patients in 5 years regaining weight if you compare non-banded to banded sleeve. And the same was true in our randomized controlled trial. With only a 3-year follow, we could show a delta and axis weight loss of almost 12%. And if you look at the amount of weight regain, this was calculated in percentage points, axis weight loss. The non-banded sleeves gained more than double of weight compared to the bandeds. So taking that all together, banded sleeve gastrectomy shows better weight loss, mostly due to a lesser amount of weight regain. And the last slide on weight loss I'm going to show you, again, comes from India. And this is a paper comparing banded sleeve gastrectomy to one anastomosis gastric bypass. And you can see, and everybody knows that OAGB has, excellent weight loss. You can see the banded sleeve gastrectomy is within range, if not even better in that study, regarding weight loss. So a sleeve has the same weight loss if you band it as a truly hypoabsorptive procedure. Now, second task, complications. This is Luke's study from Belgium, comparing non-banded to banded sleeve. And he can actually show that there was a bit more complications when in his banded groups. But this was mostly due to, well, definitely, I would say, non-ring related early complications after in his banded group, and to also a small extent, typically ring related problems, but these problems was mostly regurgitation. He called that functional stenosis at and the ring level. This could be solved by either removing or typically just enlarging the ring a little bit. So although percentage-wise, it was more, I would not consider this to be clinically relevant. And in our study, there was also a small amount of extra complication. We had, one ring slippage. This was definitely, and can't happen in a non-banded sleeve. And the most thing, and we're going to later, more talk about this, was regurgitation. But on the other hand, we had, a fair number of other complications in the non-banded sleeves. So in the end, surgical complications were equal comparing banded to non-banded sleeves. But we all know that our patients are quite young and they keep their procedure potentially lifelong. So I think even more important is the classic morbidity you have after sleeve. And I try to put this together concerning all these studies, and somebody who has heard earlier talks of mine, we, at least our group is very worried about reflux after sleeve. And we had, we're not afraid, but we had the idea that ring placement might even aggravate reflux. So we closely looked into reflux symptoms and even scoped our patients in many of our studies. And if you look at reflux after, banded sleeve gastrectomy and compare it to non-banded sleeve, you see in all these, other studies, Belgium, Italian, or Indian study, they either do not report on reflux or simply their collective has, well, obviously no issue with reflux symptoms. In our retrospective trial, we could not see a difference in reflux symptoms. In our prospective randomized trial, we did see that the patient with a banded sleeve had significantly less reflux symptoms 3 years after surgery. And I don't want to stand here saying that, placing a ring is protective of reflux symptoms. It seemed to be in that study, but we were worried about the opposite. And that, I think you can safely say that ring placement does not aggravate reflux symptoms. Now, the major morbidity we saw in all of our analyses was regurgitation. If you look at the other studies, there was a fair amount of regurgitation also in the Belgium study. In the 2 Indian trials, you could show that there obviously is a trend towards a larger amount of, let's say, even food intolerance after the banded sleeve. So it goes a bit in the same direction. The Italian trial, at least the ones I have seen, did not report on regurgitation. Now, we have 2 sets, our retrospective studies and the prospective study down here. And you see in both of these studies, there is a significant amount or significantly more regurgitation, let's put it that way, in the banded sleeves. But if you look at the amount of regurgitation percentage-wise, it went down from 40% in the retrospective trial to around 15 to 17% in the prospective trial. And the only thing we changed in these two trials was ring diameter. So I went back and put our data in one graph, and you see if you change ring diameter, the amount of frequent regurgitation goes down tremendously. But at the same time, it does not affect weight loss. So although it was not my task to talk about technical aspects of the banded sleeve gastrectomy, I would like to add this as a technical aspect. Don't use a ring that is too tight or too small. Now, the last task was metabolic comorbidity resolution. And I found two trials, actually reporting on this more elaborately, and this is Paolo's randomized controlled trial. He can show that type 2 diabetes resolution was similar comparing sleeve to banded sleeve gastrectomy, but the banded sleeves had a higher amount of resolution of hypertension 4 years after surgery. In our randomized controlled trial, we saw a tendency of a better resolution of type 2 diabetes. And I think this nicely reflects the better weight loss after the banded sleeve. Definitely, this was not statistically significant, but it was only a small amount, a small number of patients. And the same was true for hypertension. We again saw a tendency towards a better resolution or higher amount of patients that stopped using medication. But again, this was not statistically significant. In Mohit's trial, comparing banded sleeve to OAGB, well, definitely the OAGB showed a better and this, better resolution of metabolic comorbidities. But if you look at the amount of comorbidity resolution, 75 versus 86% type 2 diabetes resolution, it is within the same level. So a sleeve, if you band it, almost reaches the same amount of comorbidity resolution than an OAGB, and I think this is quite remarkable. Now, coming to a conclusion, I would say there's very dense data that shows that banded sleeve gastrectomy has a better weight loss when you compare it to a non-banded sleeve. There is no or only a small amount of added surgical complication. The major side effect of banding a sleeve, in my personal opinion, is regurgitation. Comorbidity resolution may be a bit more improved, which is not surprising if you consider the extra weight loss achieved by banding a sleeve. So thank you very much for your attention, and I'm happy to answer any of your questions.
Patrick?
Yeah, very nice presentation, very interesting. You addressing many important things like the size of the ring, the higher rate of regurgitation. We'll speak about, I think, weight loss now, regurgitation and complication. But
so very good evening to all the faculty members in the.
I just want to ask you one question regarding the management of leak when you had perform a banded sleeve. Do you have to remove the ring or not, in your experience?
Well, thank you for this question. Luckily, I have not personally experienced a leak in a banded sleeve, but we have had it in a banded gastric bypass, and we left the ring in place and it worked quite well. But we have seen other people doing it as well that have been referred to our hospital. And well, today I would do it that way. If I see the ring through the leak, I would rather just remove it, because it will keep migrating through. But if the leak is not at the site of the ring, so it's a different position, you could just might as well leave it.
Okay. Mal, do you have your experience regarding that?
Yes, our protocol calls for removal of the ring because it's a foreign body. And when you have a foreign body with the infection, there is a tendency for it to form a fistula and then a chronic fistula. So if you're in there, you do a washout and remove the ring. However, in my own personal experience, when I was still doing surgery in the States, when I had it, we had a very aggressive radiological interventional department. And they did drain quite a few of our leaks percutaneously. And we were able to manage those patients. But we got an experience from that in that even though I think about 4 patients were treated that way, the one patient did develop a gastropleural fistula at the site where the ring was, but the other 3 did well with the ring in place. But if you are in there with the laparoscopic approach, wash it out and take out the prosthesis. That's the protocol. Thank you.
I have a question. Dr. Fink, do you have any data or have come up with any data about manometry on those patients 5 to 10 years out? Because remember the history of with the band, the adjustable band that we had was a lot of them had issues with dysphagia too, not reflux. Actually, when you look at the data, patients that had reflux and had band, actually, they did better with the band, which is very interesting. There's actually a randomized control trial on that shows that. So I was expecting for you to also see the same thing for the band. But I'm really interested to see what's going to happen long term with esophageal contraction and distendability. So I'm just curious if you guys have come up with that or have you looked into that at all. A great lecture.
Thank you. Thank you for the question. We don't have any data yet. I mean, our first, big set of banded sleeves is approaching 10 years now, and we definitely do plan to reevaluate all these patients. But we haven't done any manometry studies on these. But I mean, I fully agree with you. That could be the case. As we put the ring loosely around the sleeve, I do not know if it truly does the same thing as in the lap band, but well, possibly it does.
Thank you.
I would add to that in that I looked at my data since I started placing the ring around the sleeve around 2003. We have approaching almost 18 years. One of the things we observed, at least within 10 to 12 year period, was there was no case of a mega esophagus, as opposed to something that we saw frequently with the adjustable band and something that we saw with the laparoscopic vertical banded gastroplasty. I think the mechanism of the non-adjustable ring placed loosely around the pouch teaches the patient to gradually adapt to the procedure, and therefore the patient does not start by eating large quantity of food and then dilating the proximal pouch. I still have not seen one, and now you in this group here with Luke Lemons, I think we've done the most amount of sleeves with the pseudopolaris. Has any of you seen a megaesophagus? No?
No.
Okay, that has a lot to say about the mechanism, whereas that is something we saw frequently with the VBG. The second thing is regurgitation. We have to study it. When I came to India 5 years ago, that was a big concern. And we had a nutritionist try to document as much as possible the incidence of dyspepsia, regurgitation, vomiting, and we categorized that. And interestingly, we were surprised that the incidence was almost equal to the ones of the patients who had a sleeve without a ring. It is just that when the patients who have a ring complain, the doctors take better note of it and they have a cause for it. Whereas a patient who has a sleeve without a ring, when they regurgitate, we realize that it is due to the restrictive mechanism, and it's due to the fact that the patient is taking a little bit more food than that pouch can contain. We are collecting that data, and hopefully we'll publish it to show that there is just slightly an increased incidence of regurgitation, and most times these are controlled by nutritional counseling. And as I said in my presentation, even in the patients where there have been regurgitation, we have asked whether they want the ring out. They said, no, I know why I regurgitated. I know what I did. I took a bite too big or I ate too fast. Do understand that. And that is what bariatric surgery is all about. Use the tool, and the patient knows when they're not doing what the tool intends for them to do, and then adapts, and then the procedure is effective. Okay, that's my comment about that. At this time, we'll move on. If no other panelist has a question for Dr. Fink.
Just, are you banding all of your sleeve today, Jodok?
No. We're just banding parts of it. And I found it interesting when Mal showed who to band, and this is, we have, at least in the sleeves, I know we don't have any good data on who actually profits from banding the sleeve, which patient subgroup does. And what we do, we just do the same thing for the super obese. We actively offer a ring, and for the rest of the patients, if they specifically ask for it.
We think that you should ban definitely the super obese patients, because if you look at the history of the weight loss with the regular sleeve, it peaks at about 2 years and starts gaining weight. Super obese patients lose weight, and about 2 years, they've not gotten down low enough. And if they start regaining weight, then they tend to go back to a super obese status. And those are the patients you have to prevent. If you have a patient with a BMI of 40 who gets down to 26 or 27 and starts gaining weight to 28, 29, that's not a problem. When you have a patient with a BMI of 58 who goes down to 38 and starts gaining weight, they get to 42, 43, 45, and then they are as symptomatic. So we stress that if you're going to offer that patient a sleeve, which we normally would not, because a patient that's super obese, we preferably would do a one anastomosis gastric bypass, which is a better procedure for weight loss. But if for some reason we cannot do that, then we would offer the patient a banded sleeve. And as I said, we try not to give it to people who cannot chew, because chewing is a requirement for these patients to tolerate the ring. Otherwise, they're going to have a lot of bezoars. I had a good experience with that when I did open surgery, and I did a lot of banded gastric bypass. There was one patient that was odontolet, and boy, we took out bezoars from her every other 2 weeks till I finally went in and removed the band, because they just swallow their food and it just sits right where the band is. Okay, we'll go on to our next moderator. I think it's Andre.
It's my pleasure to introduce to you Dr. Mahak Bhandari. He is a associate professor general surgery at the Sri Aurobindo Medical College, and also a consultant for minimum access surgery and Mohak Bariatric Robotics indoor. He's going to be talking about banded sleeve gastrectomy versus a one anastomosis gastric bypass, a 5-year study. Welcome.
So very good evening to all the faculty members and the viewers, and thank you for this kind introduction. So I would like to just start my presentation now. So I would be presenting on a retrospective comparative study with a 6-year follow-up between the mini gastric bypass, or as the OAGB, versus the banded sleeve gastrectomy. So I'm Dr. Mahak Bhandari. I'm the associate professor in the Department of General Surgery at Sri Aurobindo Medical School, and I'm a consultant at Mohak Bariatrics and Robotics Center. I work under Dr. Mohit Bhandari and Dr. Fobi. So this is our medical school above, and below is the super specialty center. So we do a lot number of cases. So here I am presenting you the data between 2010 to 2017. So we do primarily 3 procedures as the sleeve gastrectomy, the gastric bypass, and the OAGBs. And in which, if we apply a band, it can be a banded gastric bypass or a banded RYGB or a banded OAGB. And it can be a robotic or a single incision surgery. So I have nothing to disclose, but Dr. Mohit Bhandari is a consultant to J&J, Medtronics, Bariatric Solution, and Stryker and Apollo Devices. And Dr. Fobi is the founder for Bariatric Corporation. So as we all know that the sleeve gastrectomy is the most commonest growing procedure and is the most common procedure done worldwide. But due to the dilatation, the sleeve dilatation, it is the main cause for the insufficient weight loss over a period of time. So to overcome this, we have opted for doing a banded sleeve gastrectomy. But on the other side, this OAGB is a technically simpler and a safer bariatric procedure, which was introduced by Dr. Rutledge in 1997. It is also equally efficacious, and some have even reported better bariatric and metabolic outcome with this particular procedure, with very less perioperative complications. So the aim of this study is to compare the weight loss outcome and the metabolic syndrome like the diabetes, hypertension, dyslipidemia, or the OSA outcome in patients of laparoscopic banded sleeve gastrectomy versus the OAGB, and to analyze the early post-operative complication, the long-term nutritional effects, and the quality of life. So we did a retrospective study, which was conducted at Mohak Bariatric and Robotics Center in Indore in India. We did 55 OAGBs and 68 banded sleeve gastrectomy in 2011. And all the patients were followed up for a period of 6 years. So it's a very long-term follow-up. So this is a banded sleeve gastrectomy. We put a band around 3 to 5 centimeters from the G junction, and the distance for starting the sleeve is around 5 centimeters from the pylorus, and the ring size can be 7 to 8 centimeters. The volume of created sleeve is 75 to 90 cc. So the volume above the band, it is around 15 to 20 cc. This is the OAGB. Again, this OAGB, we use a pouch length of around 15 to 18 centimeters with a BP limb of around 180 to 200 centimeters. So the volume of pouch is around 45 cc only. And the diameter of the pouch is 2 centimeters. So as far as baseline characteristics are concerned, we have matched this particular study. So in 55 OAGBs, as you can see, the age group is all, and the banded sleeve, the age group is nearly same. The male to female ratio is also nearly the same. BMI is also matched. The weight is also matched. But the type 2 diabetes patient in which we did a MGB was 53%, hypertension 62%, and OSA 96%. So this is a good follow-up. As you can see that in 6 years time, there's a follow-up rate of 72.7% in MGBs, and for banded sleeve, it is around 70.5% for 6 years. So this is a very good chart. As you can just see, for the total weight loss outcome in MGBs at the completion of 4 years, there's a good outcome of 44.32% in MGBs. But on the other side, in the banded sleeve, it is 37.65. Like at the period of 2 years, as you can see that they were losing weight, but after a period of time, they started gaining weight in banded sleeve also. But in the MGBs, they started the weight regain after a period of 5 years. And at the period of 6 years, both were nearly the same. The total weight loss outcome for both the procedures at 6 years are nearly the same. But when we are talking about the excess body weight loss, as you can see, in the banded sleeve procedure at the end of 2 years, they lost much weight than in comparison to OAGB. Then again, at 3 years, again, they were losing weight. But after a period of 3 years, they started gaining weight. And at the end of 6 years, the excess body weight loss percentage was more in banded sleeve gastrectomy. So adding a band causing a restrictive effect was very much effective. And the resolution of comorbidities at a period of 6 years, as you can see, the diabetes resolution and the hypertension was more in MGBs. The resolution of OSA was around 63% in MGBs. And in dyslipidemia, both were nearly the same. So again, the MGBs, as I just said, that for the metabolic conditions, we opted for an MGB. So as you can see that for the diabetes resolution and hypertension resolution, it was a good figure of 85%. But in terms of nutritional deficiency, for patients of like for 40 patients out of this 48, as you can see, that 90% of the patient had a fall of hemoglobin. They went up from 12.9 to 10.8. So 90% patients had fall of hemoglobin, albumin also, and protein also. As you can see that protein was around 85% had protein loss while doing an MGB. And for B12s and calcium, it is around 47%. But you can see the banded sleeve in 48 patients, the hemoglobin, which was less than 12.5, the hemoglobin fall was just nearly 46% only. Protein was just 54%. So in comparison from MGB to banded sleeve gastrectomy, I can just see that there was a good fall in hemoglobin and hypoproteinemia, hypoalbuminemia in MGBs. So there is a good protein deficiency which has to be countered in MGBs. That's why we say that any bariatric procedure, or nearly, we can say that the MGB, there should be a very good follow-up with all the patients so that active intervention can be done as and when required. And in terms of quality of life, you can just see that the MGB and OAGB and the banded sleeve gastrectomy, the vomiting percentage was around 20% to 14.5%. But you can see that in the MGB patient, there is some problem, like there is a frequent malodor in the flatus, there is complaint of body odors and feeling of hunger all the time. So it is the malodor flatus around 22.5%, which is not seen in banded sleeve. Body odors, it is around 20%, and feeling of hunger is around 17.5%. So the quality of life is like there's a bad odor in the while passing gases. So it is like we can very well identify the patient of MGB. So it is somewhat poorer in MGB while comparison to banded sleeve gastrectomy. Complication at our center in this particular study in MGB, there was an anastomotic leak in only one patient. There was a marginal ulcer in one patient, and we had to revise the procedure due to hypoproteinemia in only one patient. And hemorrhage was the same in both these studies, in banded sleeve and MGBs. So the discussion, as you can see, that these all surgeons have done in MGB, like Dr. Mohit Bhandari, Dr. Rutledge, Dr. Lee, Dr. Kular, Jammu, they all have done these all procedures, but for a period of 6 years, as we can see that in our study, there was an excess body weight loss of 79.4% with a diabetes resolution of 86.2%. and hypertension resolution of 85.3 with OSA resolving in 66% and dyslipidemia in 53% in OAGBs. So it is a very good procedure as far as metabolic conditions are concerned. At the other end, in banded sleeve, it is also a very good procedure. That's why banding the sleeve is very much important. So in our study, as you can see that the excess body weight loss was around 82%, which is a very good weight loss. The diabetes resolution was 71.4%. The hypertension was 64% resolution, and the OSA resolution was around 50%. So also the banded sleeve is also working very well. So concluding is that banded sleeve gastrectomy is equally good procedure for weight loss as compared to MGB, OAGB. There is a better resolution of metabolic conditions, and it is achieved more with OAGBs. That's why we prefer OAGB in patients with high diabetes and OSAs and dyslipidemias. But on the other hand, nutritional deficiencies are seen more in OAGBs, and the quality of life is somewhat poorer in OAGBs as compared to banded sleeve gastrectomy. So in some patients in which we cannot attempt a sleeve gastrectomy, or we cannot attempt a OAGB, we can very well do a sleeve gastrectomy, but we should band that particular patient so that the weight loss outcome and the resolution of conditions can be done effectively in these particular patients. So this is my team. So I would like to thank you again for giving me this opportunity, and thank you.
Andre?
Great presentation, Dr. Bhandari. I wish I had a team like that. That's a pretty large team in the picture. So quick question. Great comparison, great study. I applaud you guys on that. So if I get this correctly, you would choose a mini gastric bypass versus a banded sleeve gastrectomy based on metabolic profile of the patient, correct?
Yes, sir.
All right. So can you run to me your algorithm in choosing those patients? I mean, does the BMI get into weight? What else comes into when your workup to choose one versus the other?
So what we have devised at Mohak is there's an algorithm made by Dr. Fobi, and seeing the number of procedures which we have done, like over a period of time, what we have seen from the BMIs, any BMI more than 45 to 50 would be chosen for an MGB with, and if the BMI is more than 35, but with the patient with high diabetes or dyslipidemia or severe OSA, then also we can go for an MGB only. And for the patient with banded sleeve, any patient with a BMI more than 35, but if at all he doesn't want an MGB, because see, there's a notion here that MGB can cause protein deficiency, and in India also the people are more of a vegetarian diet. And if you want to do a sleeve, so we do a banded sleeve on those particular patients. So for your question, that what is your algorithm for any BMI more than 50, we can go for an MGB only.
Okay, thank you so much. And I know this is not your talk. I'm just curious right now because you guys really are waking my appetite for the banded component.
Yeah.
When do you do a banded mini gastric bypass or one endoscopic bypass versus a non-banded?
Sir,
I'm just curious. So I'm very curious on that.
Sir, it all depends on, like, when we counsel the patient, using a band is mainly for just restricting his diet and then for the weight recidivism. So we ask the patient that, would you like to opt for a band or not? It is not that we give band to each and every person. Band also has a cost. So cost is also a matter of concern. So that's why we band the patient, but it all depends on the patient choice also. And if at all, we have got a very high BMI patient, very well we can go for a staged procedure also, but for a very high BMI more than 60, we can do a banded mini gastric bypass.
Okay, thank you very much. Outstanding presentation.
Mohit, do you want to address that about when you band the one anastomosis gastric bypass?
So, hello, Andrew. It's an interesting question because I get this question quite often. It's not something as a routine which we do. Basically, we started doing some prospective studies. We wanted to see if it really makes sense to band mini gastric bypass because we were seeing some of the weight regains in the mini gastric bypass at 3, 4 years, 5 years follow-up. Because as you understand, we started decreasing our limb lengths from 250 to 300 centimeters to around 150 to 180 centimeters. So these mini gastric bypasses were behaving like a Roux-en-Y gastric bypass. And I don't agree with most other surgeons across the world who say that a limb length of 150 centimeters is good enough for a mini gastric bypass. We started encountering the same amount of weight regain like a sleeve or a banded gastric bypass or a normal gastric bypass without with this kind of limb length. So I decided with Professor Fobi that let's do a prospective study where we band MGBs and then compare them. So this is only as a part of study where we are banding these mini gastric bypasses and not as a routine. So I think we will be publishing this data. We are still collecting it. And once we have something which can be presented in the form of a paper or maybe the data is sufficient enough to justify publishing a paper, we'll come up with our data.
Thank you very much, Mohit.
Routinely, you are banding all your sleeve today, I think.
Yes.
Routinely, you don't band the mini bypass today.
Yes, we don't band them. We band our sleeves because we already published the 6 years data. And now we have a lot of data with banded sleeves. We are particularly convinced that banding of sleeves work. But we are not convinced because we don't have that kind of data with the banded mini gastric bypass.
I remember we had this talk, I think 2 years ago. So what's your strategy? If you want to go to a banded sleeve, you go to a mini bypass. are you removing the band of the sleeve or not?
Okay, so you mean to say if I want to convert a banded sleeve to a mini gastric bypass? So I never had a chance to revise a banded sleeve. we had fantastic weight regains with banded sleeves. We only converted them when we had some complication, like some band erosion or a band stricture. But I do not remember any case of banded sleeve where we had to revise because of weight recidivism.
Interesting.
Okay, so now I have the honor of inviting Professor Lew Clements. As you know, that Professor Clements has done extensive work on banded procedures, and whenever we sit together and we discuss our data, you know, we cannot agree more with each other. So today I thought it's a good platform for us to invite him to speak upon how he compares his banded sleeves to his banded Roux-en-Y gastric bypass. Because is there a place still, because, you know, if you ask me, and Professor Fobi would agree that banded sleeves are giving some very good results to us. In fact, even in diabetic patients where we had to do that. So I would like to invite here Professor Lew Clements, and would like to understand his opinion, his data on the comparative analysis between the banded sleeves and the banded gastric bypass. Professor Clements, I have already introduced at the beginning of the program, so the stage is all yours.
Hello, everybody. Thank you, Dr. Bhandari and Dr. Fobi, for inviting me. And thank you, Mohit, for this very nice introduction. So my name is Sir Clements, and I'm working in Bornem. This is the northern part of Belgium, and also in Brussels. Since there are no publications comparing banded sleeve and banded gastric bypass, we used our own data for this presentation. I have only a teaching relationship with Bariatric Solutions, and this is our case mix disclosure. As you can see from the beginning of our surgical career, we already performed bariatric procedures, and we did more around 4,300 primary bariatric procedures. In the first 20 years, we mostly performed biliopancreatic diversion following Scapinaro, and we did more than 2,000 procedures of this. Since 2000, we changed to the gastric bypass, and we performed now 1,650 primary bypasses, and the great majority were banded. And we also did some sleeve, a little bit less, but still 440, and also here the majority was banded. And in the last years also the OAGB or mini bypass receives more interest in our service. We started with Fobi's ring, of the gap ring, and in 2012 we changed to the minimizer ring. The advantage of this ring is that it's only one ring with 4 different sizes, but also there is a needle with soft tip, which makes it very easy to bring it around the pouch in a bypass and in a sleeve. What about our technique? We make a vertical pouch of around 7 centimeter length, around 34 French nasogastric tube. The ring is placed at 4 centimeters of the EG junction, and we need at least 3 centimeters below the ring if you want to do gastroenterostomy by linear stapling. For the sleeve, we use a 40 French nasogastric tube, and also here the ring is placed at the same height, around 4 centimeters from the EG junction. The length of the ring is mostly 7 centimeters, especially in female patients. In male patients, we sometimes do 7.5 centimeters. And in the sleeve, in most of the cases, we will put the ring at 7.5 centimeters. And this is how it looks in real. You see here in the bypass, the ring is placed at a length of 7 centimeters and still some place left between the pouch and the ring, even with the tube inside. And we have our 3 centimeters if you want to perform a linear gastroenterostomy. This is a sleeve. You see that in this case, the ring was placed even on 6.5 centimeters, but it was a redo operation and the patient insisted to make the ring as small as possible. Normally, we should place the ring here at least at 7 and even now at 7.5 centimeters. The data we used in this presentation are published in obesity surgery, and from the bypass and the sleeve, we published a cohort study with a 5-year follow-up and with a follow-up around 90% of our patients. If we compare the results at 5 years, and here we see the evolution of the weight loss of the banded bypass, and already at 1 year, there is a difference in favor of the banded bypass, and at 5 years, we have a difference in weight loss in 8 kilograms. And while the curve is staying near horizontal for the banded group, there is a tendency of weight regain in the non-banded. And the same we see for if we compare the sleeve. Here we compare the evolution of the BMI in the sleeve. And there was BMI a little bit higher, 2 points higher in the non-banded group. But if you see at 5 years, there is a difference of 8 points in BMI for the banded sleeve if you compare it with the non-banded. And if we put the evolution of BMI of bypass and sleeve one on the other, then you see that at time of operation, the BMI of the banded sleeve was 2 points higher in the sleeve, and at 5 years, 2 points in BMI lower for the sleeve. What makes a difference of 4 points in BMI in favor of the sleeve. The other difference, the only difference was the male-female ratio, and in the gastric bypass, there was a male-female ratio of 2 males for 5 females, but in the sleeve, the majority were males with 3 males for 2 females. We don't know if this can be an explanation for the 4 point difference in both procedures. There were no band placement complications and also no band-related complications in the first weeks or months after the operation, and this concerns about 1,800 banded procedures. When we consider the band-related late complications, and again, these are data after 10-year follow-up, and these are no published data. And you see that we had migrations of 7 rings in the bypass on 1,330 banded bypasses, which makes 0.5%. And for the sleeve, it's only 1 migration, that makes 0.3%. The same for the slippages, 0.45% for the banded bypass and 2 or 0.7% for the banded sleeve. There was some late dysphagia or even stenosis, but less than 5% of the ring needed to be removed, and it was because of fibrosis, from functional stenosis, or even, and that's also important, patients' incompatibility. And this is an example of a migration of a ring, and this was a picture of 3 weeks ago. It was one of the first things we placed already more than 10 years ago. And this patient came to see us because of dysphagia, and the gastroscopy showed the migration of the ring, and this could be removed easy by endoscopy. And this is really important. It is much more easy to do it by endoscopy, but if you see it when you don't expect it by laparoscopy, it makes it more difficult to remove it, and then you have to close the hole on a small pouch, what makes it not always easy to avoid another stenosis. And this is an example of a slippage on a bypass, and you see there was stenosis, a late dysphagia, and the ring, in this case, the ring is really lying on the gastroenterostomy, what causes the stenosis. But another problem, and this is more important when the small intestine and the jejunum is slipped through the ring. And this is an emergency because this gets incarcerated with a necrosis, and in one case we had to do a cutting or a removal of the gastroenterostomy and to make a new gastroenterostomy. And this is a nice example of a slipped ring on a sleeve. Normally the ring should be there where at this point by the arrow, and this is the view during the operation. And what is important is that this ring, and this is also 1 year after the operation, so you see that there is no fibrosis at all, and this is also the reason why this ring can slip, because in most of the cases, most of the patients, the ring is covered by a small layer of fibrosis, what keeps the ring in place. So in this patient, it was easy to open the ring of a centimeter, put it in place again, and fix it again by some stitches, non-resorbable stitches, of course. So what can we conclude if we compare our own data now? That, of course, the banded bypass and banded sleeve are our procedure of choice. And because there's only an extra operation time of few minutes, and there are no perioperative ring-related problems in 1,800 of these operations. And there is a better weight loss and also less weight regain in the banded procedure. Exceptional reoperations for weight regain in the banded group. There are few ring-related problems with the rings that has to be removed, and less than 5% in both groups. We had the migration of the ring in less than 0.5%, and the best length of the ring is maybe 7 or 7.5 for the bypass, and maybe 7.5 for the sleeve. Thank you for your attention, and I'm happy to answer questions if you have. Thank you.
Mohit?
Lemons?
Yes, I'm still here. Okay.
Can you hear me, please?
Yeah, perfect. Can you hear me?
Yeah. I can now hear you.
Okay, perfect.
Great presentation as usual, and I have two questions for you. My first question is that in your practice, I know you have a wide base of practice. When do you choose a banded sleeve, and when do you do a banded gastric bypass? So how do you choose between these two?
Let's say when we finished this publication on the banded sleeve, we were convinced that the banded sleeve was at least as good or with very good results at the long term. And when we choose, most of the procedures at that time were banded sleeves. That makes sense. We nearly did 400 banded sleeves now. And then came the publications on esophagitis and even Barrett's with, and then we came back a little bit to the bypass. That's why I still do much more bypass now. But what we do now, and it's mostly the patient's choice. If there is an esophagitis type C or D, of course we will go for a bypass. If there is too much reflux at that time and the patient is very heavy, we will go for a mini bypass. And we mostly we will put a band or a ring also in a mini bypass, because patients come to me especially for the ring. That's why I choose it for that. And but I put ring on one anastomosis also very large, 7.5 centimeters, because the pouch is a little bit larger than we put in a regular bypass. But it's mostly a patient choice. And if we compare both techniques, some patients in Belgium will want a bypass of the sleeve, except in those few cases where there is already too much esophagitis.
Okay, great. my second question to you would be that if you have a ring erosion and you feel that it can be dealt in by endoscopy, so do you do your endoscopies or you have a gastroenterologist to do it? And how do you remove these rings? What's your technique of removing them by endoscopy? Do you use a double lumen scope, a single lumen scope, and what sort of scissors you use to cut and remove these rings whenever you have these complications?
So the last one you have seen here was removed. Always the gastroenterologist who does it. I am not used to do gastroscopies. So, but last time I used a wire to bring around like I did before for the adjustable bands, but the same technique, bring a wire around, cut and take it out. And the advantage of melt ring is that it's easier to take it out because it's not really fixed with like with the two ears of the minimizer ring. So we took out two rings. I remember by endoscopy, and but I had to remove also at least one, and other rings were removed in other centers also, because that's why I'm always saying now, always do a gastroscopy, and because sometimes you don't think about, you think there is a stenosis, be going to open the ring, and then you see that there's a huge amount of fibrosis. It should be better than to go out again and ask gastroenterologists to take it out. You could do it because you do it yourself during the same procedure, but I once tried to do it by laparoscopy, and it's not always easy because there is a lot of fibrosis. You take it out and you have the hole, of course. It's not easy to close it completely. Okay, we managed, but so the best thing is to take it out by endoscopy. And I think the best thing to do is to do it by, with the wire. We can cut the ring. But we have no scissors to do. Okay.
Yes.
How do you do it?
So we have a separate. So we do our endoscopies ourselves.
Yeah, that's advantage.
And that's an advantage to us because I have never used so I do it myself, and we use a double lumen scope, and I have a very stout, very strong scissors where I cut my rings and I remove it, and we have done it by using a double lumen scope. So through one of the channels, we put a nice grasper, so we can rotate the ring through the grasper.
Is because when the ring is very well fixed with the two ears of the minimizer ring, it can be difficult. No, if
so that's what I'm saying. So the technique is that you need a grasper. So you can hold the ring with the grasper and rotate it. And once you rotate it, the ring can, come inside, and then you can use a stout scissors. And these are not the routine scissors. We have special scissors, and these are not available in most of the countries. They have to be made specially. They are very strong scissors. So you can cut virtually any ring or a band, and we need a double lumen scope. So this is, and I remove all these rings. I even remove it for some other surgeons, although not many surgeons in India perform these banded procedures, but I have done it for others as well. And we have removed a lot of them. A lot of them we have removed just by endoscopy. But I know that most surgeons, they cannot remove these rings, and they have to send these patients to a gastroenterologist. And sometimes even they are not able to remove because they just use the routine single lumen scope. Whereas, to be honest with you, as you correctly said, there's a good layer of fibrosis which happens over these rings. So you have to rotate the ring, and then you have to use a grasper to rotate it inside the lumen, and then cut it with a very stout scissors. So that's why I asked this question, because you're doing such huge volumes, and these erosions are common with us. I mean, 2 to 5%, and we deal with them. And whenever I get an erosion, I take at least half an hour to remove that ring. It takes some time to put in a double lumen scope, and then there's a little bit of maneuvering required there. So I always was very, I wanted to know this from you, that how you deal with these situations, because we had the hard way to learn. We learned it ourselves. But yes, then we realized that, yeah, it's, I use the argon energy source. Sometimes if I see the thread, so thread can be cut by the argon source, but rest all I cut it with the scissors and remove it.
Yes. But the problem is also, as you said, those people are, when they have some problems, they have tendency to go to other hospitals, but they always think it's the grass is greener elsewhere. And that is the problem, because those people are not used to manage these things. And then I don't know what they're doing, but I go in by laparoscopy. There are, I heard from one case that even at the perforation of the heart. I don't know how you do that, but you see, it can be, if you're not, you can make mistakes if you're not used to treat them. That's why I'm always telling them, if there is any problem, please come back to us. And then at least go in and by endoscopy, it's mostly easy. But okay, we only have 0.5%. It's not that high, but you're telling me you have more than 2% of migrations, or even 5%, or what? If I understood you well.
Thank you, Professor Lemons. It was a great presentation as usual. Today we were to have a live case, but unfortunately, as you know, that Indore has gone into a state of lockdown, and we are not permitted to do live surgeries or do elective procedures here in Indore anymore. One other hospitals in Indore tried to do it, and they were given a notice. So I requested Professor Fobi that we refrain from doing live or virtual live today. We are in a bad state of affairs here in Indore. Today we had some 2,000 cases and around 50 mortalities. So the entire hospital, everywhere, all around the places are full. There are no beds in the ICUs. It's one of the worst times I have seen in this city. So I just thought maybe we avoid doing a live case or live virtual today, just to avoid confusion. A lot of people watch us on the Facebook, so I requested Professor Fobi and he agreed. So over to Professor Fobi. I thank you very much for attending this fantastic webinar. I'm informed that the situation is going to improve by next week, and hopefully by next VBUs we're going to have live case. I think this is the first VBU where we never had a live case in the 24th episode. We always had one.
Well, thank you very much. Thanks for the faculty. It's been a good exchange. There have been Vishal, are there any questions from the audience I'm missing? I know somebody has their hands up.
No, sir.
Okay. All right. Thank you, Andre, Luke, Jodok, Dr. Ramesh, Mahak, for taking the time to come to this webinar today. We have another webinar next week on SADI and BPD. Here is the promo.